Thank you, Mr. Chair, and I want to start by thanking our witnesses for joining us today. And I do also want to wish everyone a happy International Women's Day. Dr. Fisman, I share with you the view that we need to learn from this situation, and we need to start thinking about what we should be doing working forward. You're based in Ontario, and you've been working with the provincial governments on the vaccine rollout. From your perspective, can you talk about the work that provincial governments need to do in order to ensure that currently we have a rapid and an efficient vaccine rollout?
So just to be clear, I don't have a role on the Ontario vaccine task force at all. I'm on the science table in Ontario and the modeling table, and I can give you my perspective as someone who's more looking at data rather than designing systems. But I can also, I think, possibly make a comment as a physician. I think to my mind, we're doing some good stuff. The marvelous observation over the last month or so is we've had long-term care facilities in Ontario serve as a major source of death during this pandemic. And the Pfizer vaccine and then the Moderna vaccine have basically shut that down. And our science table has a brief that came out today looking at the impact of these vaccines in long-term care. It's nothing short of spectacular. I think that if there's a major failing that I see in Ontario that's holding us back, and I think we are starting to fail to keep up with vaccine supply as it comes into the province. We have about 9,000 family doctors in this province who vaccinate a few million Ontarians against influenza every flu season. And I'm aware of the logistical issues with the mRNA vaccines, but we're starting to get into vaccines that don't have the same extreme cold requirements for storage. I think family doctors know how to do this. They know their patients, they know how to prioritize, and they know how to get folks vaccinated. I think there are some infection control concerns in terms of individual people's offices, and not all docs feel comfortable having a large crowd of folks pass through at this time. But I do think that that's probably, as we try to do something new, I think we have to use the tools that we already have in our toolbox. And we do have this group of individuals who are very, very good at vaccination who have been underutilized to date. So I hope that changes. I think the thing I'm proudest of in terms of the Ontario Science Table, and it's brought me along a little bit, is usually, and we see this every year with influenza vaccine, usually the dilemma with vaccination is that vaccines are least good at protecting the individuals you most want them to protect. So with influenza each year, most deaths from influenza each year occur in individuals over age 65, for whom traditional influenza vaccines, we've got some better ones now, but traditionally influenza vaccines have arguably not worked at all in that demographic. So we've directly tried to protect individuals with vaccines that are very unlikely to work in that age group, whereas we could probably protect them more effectively by going for the herd, because the flu vaccines work in younger people. We don't actually have that dilemma with COVID vaccines, because the mRNA vaccines in particular are so potent that we can directly protect individuals over age 80, over age 70, individuals with underlying medical issues by directly vaccinating them. So to some extent, this decision's been a bit of a no-brainer in terms of who do you vaccinate first. It's older people, and I think you see that in other countries. The modification to that's come out of our science table is there's this observation that about 90% of all of our COVID cases come from 10% of our postal codes in Ontario. And those have been overwhelmingly postal codes that are more densely populated urban areas, lots of people of color, lots of new Canadians, lots of folks involved in essential work. So what came out of the science table, and I think the province is now following this, is an attempt to sort of front load, in addition to prioritizing older people and folks with underlying medical conditions, to try to front load vaccination in some of these zip codes that have been really the hardest hit, to try to get some of those herd effects as well. And I think it's a neat piece of nuance. I realize it's raised equity concerns in other areas where people have said, hey, what about us over here? were vulnerable too. But I think these are hard decisions with a scarce resource, and I think they did pretty well with that.
A lot of these decisions are database, Dr. Fisman. So I'm hoping you can expand on the tools that are available to the provinces and the territories, such as testing, contact tracing, public health measures that would get us through this crisis, and the importance of data and how data can help lead the decisions that we need to effectively counter the effects of this pandemic.
Right. So I think increasingly public health has become a data-focused discipline. I mean, how we understand processes, how we see them, really depends on the data that we have. It's unfortunate, I think, in my province in Ontario, we have a bit of a track record where we've sunk billions of dollars into data systems and famously have had very little to show for that. So I think that is sort of a caution to us as we say, let's just throw a bunch of money at this and build some good data systems. We have needs on a bunch of different fronts. In terms of public health surveillance systems, we could really use some upgrades that make surveillance systems interactive, kind of have crosstalk across the country, shared vocabulary, sort of a relatively user-friendly data systems, and data systems that are actually linked into, we have national healthcare in Canada. It would be great if we could actually have interactivity between our public health data systems and our healthcare data systems. On the subject of vaccines in particular, because that's sort of what I had been thinking about heading into this meeting, we are really, really patchy and have very little that's been constructed to date. As far as I know, the only province in Canada, and I hope I'm right about this, is that has an adult vaccine registry is Prince Edward Island. I think that's it. So we really don't know. As I mentioned in my remarks, we spend $500 million annually on vaccines, but we actually have no means of tracking who got them, linking that to health records so that we could look and see, if you're vaccinated, are you less likely to be hospitalized and so forth. We're really struggling in terms of appointment systems. We don't have a good national nimble system to monitor vaccine adverse effects, which is a really big issue with brand new vaccines.
I'm going to have to cut you off right there.
Sure, sorry.
So thank you very much. Excellent information.